Hi.
Hi, are you there?
Yes. Hi, Lisa.
I am so sorry for the technical difficulties. I really do apologize for this delay, but we are ready to go. So, good afternoon and welcome to the Specialty Care Initiative Technical Assistance Webinar Series, which will focus on each implementation strategy cluster and the various successes and challenges and approaches coalitions have pursued on the path to access specialty care for the uninsured and underinsured across our state. As I said, this is Louisa welcoming you. I am the Technical Assistant Senior Program Associate working with Bridget Hogan-Cole, Director of Technical Assistance. Bridget regrets that she can't be with us today because she's launching this year's Building Clinic Capacity for Quality Improvement, or our BCCQ program, which is the other initiative she manages. So she sends her best, and she has passed the facilitation baton over to me, so I will be your host facilitator. Okay, just to move on to our objectives. Let's see.
And Lisa, you can go ahead and control the PowerPoint.
Okay, so I just click my mouse, right?
Yeah, you should be able to.
Okay. All right, well, not going. All right. Well, Gabby, would you mind just doing that for me then?
Sure.
Okay.
Just 1 second.
Okay, just briefly, our webinar goals are to provide a forum for sharing of best practices and peer learning, to offer support and resources for you, and to encourage networking and collaboration among our coalitions. We really hope that you'll view this 1 hour in your week for the next 3 months as the time and place to come together with your colleagues, to share and to ask the questions that you always had about implementing strategy clusters but were too afraid to ask. So please, have no fear. We're all on this journey together. I'd like to mention that the webinars are also open to members from your coalitions, and they are welcome to listen and participate. Today's webinar is focused on embedding guidelines into the referral process, and simply stated, guidelines will help improve our knowledge of the various diagnosis and treatment options for special medical conditions. And ultimately, they get integrated into new or existing referral systems, as you know, resulting in better management of appropriate referrals. So there are many approaches to developing guidelines, and some teams are farther along than others. So to help spark our discussion this afternoon and to delve further into our strategy cluster discussion, the Ventura County Safety Net Specialty Care Access Coalition has graciously accepted the invitation to share their approach with developing guidelines. However, before I introduce them, I'd like to briefly review our standing agenda and format for our webinar series. So if you would please get the agenda.
You know what, Lisa? I didn't get to upload that again.
Okay. All right. So we will, let me just review that with you. I know that that was sent out. We will be sharing, as I said, our successes and challenges with each of the strategy clusters, and that will be done in the format of either having a presentation by our coalitions or having an entire group discussion, or if you wish, have a subject matter expert or experts come in and delve more into each of the strategy clusters. So again, this is your time. This is really for you to tell us what's working for you and what you would like to see happen with these weekly discussions. And, of course, we will discuss the challenges involved in the process and how we can really overcome them and share best practices, as I mentioned. And we will also have a question and answer time. And at the end of the session, we would like to just get your feedback again, do a little brainstorming on how you would like to format the following session. So as you know, we will have this every Tuesday from 12 to 1. And the next session on embedding guidelines will be on April the 6th. So we'll talk about which format you would like then. Okay, so again, a quick reminder, please be sure to turn off your cell phones, mute your phones, either on the web using *6 or highlighting your name in the box, or use your mute button on the phone. But please do not place your phone on hold because your hold music will come through. And again, please mute during presentations and unmute during the open section. And if you'd like, you can also ask a question using the chat box if you're on the web and type a question in there for our presenters or for whomever you'd like. So lastly, I believe I mentioned these sessions will be recorded for future playback and posted to CCV. So I just would like to take a quick roll call for today. Again, I apologize for our technical delay here. All right, El Dorado, Humboldt, Health Alliance, Shasta, Alameda, Yolo, Contra Costa.
Sarah and Maeve.
Great, thank you. Santa Clara.
Joe Sexton.
Great. Fresno.
Simon.
Thank you. San Joaquin.
Jeff Slater.
Thank you. Marin. San Francisco.
Hi, this is Karen Leeds.
Thank you. San Mateo. Solano.
This is Vina Ford.
Hi, Vina. Long Beach.
Hi, this is Haley Abel.
Great. San Diego.
Hi, it's Christy Rosenberg.
Thank you. East Valley. Kern.
Charlene Chen.
Thank you. LAC USC.
Hi, this is Anna Alvarez.
Thank you, Anna. Southside LA.
This is Nina Vaccaro.
Hi, Nina.
Hi.
Valley Care.
Hi, this is Johnny.
Hey, Johnny. Westside Venice. Okay. Any funders?
Come on, Dave O'Neill.
Hey, Dave. Thank you. Did I miss anyone? All right. Thank you.
This is Michael Cox from Kaiser Permanente.
Thank you, Michael. Okay. Well, now it is my pleasure to introduce Diana Casey, who's a nurse and has a master's in nursing. She has been at the Ventura County Healthcare Agency for 12 years and has been living in Ventura County for 28 years. So she's seen lots of changes in the healthcare system, especially as it relates to the uninsured. We're also very fortunate to have with her Dr. Dwayne Pearson, who's a lead specialist on the Ventura team. Welcome, Dr. Pearson.
Thank you.
And thank you for taking the time out of your busy schedule today to be with us. So
It's a pleasure.
thank you so much. And again, I apologize for our delay today. So take it away, Diana.
I wanted to introduce Dr. Pearson to you. Dr. Pearson is a rheumatologist, one of our specialists. He is also the specialty medical director for all specialties in the healthcare agency and ambulatory care clinics, as well as the medical director for the Kaiser Grant Specialty Care Initiative. And I'm going to let him do the first few slides. Thank you.
Boy, that's a lot to live up to. How do I make these slides move?
Hi, this
I'm
is
now the
Kathy.
presenter. Okay.
I just gave you the presenter role.
I just changed it. Great. So our county is, I feel, very unique. I just moved here 3 years ago from University of Colorado. It's a wonderful mix of rural, urban collection in between urban centers such as Oxnard, Ventura, and Thousand Oaks, and then large interspersed agricultural areas. Our total population at the last census is 7,999. We've clearly are approaching the 900,000 mark by now, but we'll wait for the next numbers. Our ethnic makeup includes a majority of white Caucasian, but there is a very large Hispanic/Latino population here as well that provides some very interesting mixes and challenges. We have a very high poverty rate with 6.4 falling beneath the poverty line. Our primary employers in the county include military base support for the Magoo station, as well as there's a CB base and a naval base on Point Magoo. Very large agricultural base, including all forms of citrus, strawberries, avocado. We're If you've ever seen Driscoll Strawberries, they're based out of here. And then we also have biotech with Amgen and Thousand Oaks. We're also the Center for Patagonia, if any of you are outdoor enthusiasts. Our medical center is of modest size. It's 220 beds, but we've, in the last, believe it was 4 years ago now, Diana? 4 years ago? We reopened Santa Paula Hospital, which is located in Santa Paula, which is a community of about 60,000 people. That's primarily agricultural. It has 49 beds as well. We're the home for a very strong family practice residency program that has approximately 40 to 45 members. We have a very robust ambulatory care system with over 450,000 visits per year. We have behavioral health, public health, and coroner services. We have a hub and spoke referral pattern where we have our main hospital, which is located in Ventura, our satellite hospital in Santa Paula, and then multiple outlying clinics, including 14 primary care clinics dispersed throughout the relatively large geographic area that comprise Ventura County. And there's also 16 specialty clinics, which include a pediatric diagnostic center, Mandalay Bay Women's and Children's Group. There's a central orthopedics clinic at the main hospital, but then there are smaller orthopedic clinics that are staffed in Oxnard and Fillmore. We have hematology, oncology, pediatric, hem-onc. We have a medical specialty clinic that is under my directorship, which is in Ventura, as well as there's another satellite in Oxnard that allows us to develop multi-specialty approaches at the time of visit. We house, depending on the half-day, gastroenterology, endocrinology, nephrology, pulmonary, and rheumatology, as well as having neurologists at those sites as well. I just outlined multiple medical specialties. We are underserved in multiple specialties as well. Prior to my arrival, we were underserved in rheumatology. We are up and running full. We still are in need of help in dermatology, gastroenterology, pulmonary. Through the work with the coalition, we've been able to address some of our areas of more pressing need. We also have specific pediatric specialties. We're very fortunate to have this. We have Francisco Braccio, who's in charge of our hematology oncology for pediatrics, who is closely affiliated with Children's Hospital of Los Angeles. We have pediatric ophthalmology, endocrinology, nephrology. The list goes on, as you can see.
We started our Ventura County Safety Net Specialty Care Access Coalition 2 years ago in March. I keep wanting them to change the name because it's so long. But it is the guiding body for all our grant strategies and for helping to look at the needs for increasing specialty care for, obviously, the under- and uninsured populations. We have a great participation by specialists and primary care providers, and we're increasing our participation with the community clinics by doing more outreach in that area. Okay. How do you get it to the next slide? Oh, there we go.
There you go.
All right. It's grown from the original 19 members to now we have over 27 members. We do have a large membership, but remember the vast majority of our physicians, and it's, our participation rate on a given meeting can be anywhere from 15 to 17, depending on what their day is looking like and if they can, run away from their clinics for an hour for lunch or so. And that's why we're bringing these meetings out into the community, and we might even look at different times for them. Our newest member is a hospitalist at Ventura County Medical Center and a physiatrist, and Dr. Pearson will explain what a physiatrist is to you, and then more primary care physicians from our community clinics. And it's strengthened by an active participation, especially with the specialty guidelines. Next slide. I want to talk a little bit about our challenges and our successes, and I also want to have you notice the pictures that are on this PowerPoint are pictures of Ventura County, and it really gives you an idea of the diversity of the county and how beautiful it is. As I said before, we have a really energetic participation by our specialists. They're very interested in making the guidelines something that's usable for themselves and for our primary care physicians. We have participation by the Ventura County Medical Association, and one of the reasons I'm particularly fond of bringing that up is that he is a psychiatrist, and I know in the grant psychiatry was really not included as one of the specialties, but as a sideline, we've continued down that road of working with our behavioral health department, and because of the stimulus from this coalition and from the grant, we now are entering into an age where we're going to have behavioral health and primary care integration in our clinics with licensed clinical social workers, and we've also got our behavioral health psychiatrists with the work of Dr. Pearson to now accept patients for referral from our primary care physicians for a 1 to 2 visit assessment for, say, medication reconciliation or diagnosis verification, and this is very new and very exciting in our system. As I stated before, we now saw the need to reach out further into the community, and we are working on that every month. We want to strengthen that link that we have with the healthcare agency, which is, pretty large, as you've already seen, with our community clinics. And so our next meeting in March is going to be held in Oxnard, one of our cities, at one of the community clinics rather than at the central hospital location. I want to talk a little bit about the achievements, and I'm going to turn this over to Dr. Pearson.
So looking at the demographics of our county, we found that one of the significant needs that we're facing is treatment of diabetes, and there are significant barriers to care to appropriate screening. So there was the idea that we could actually somewhat obviate the need to have every patient go through routine dilated screening by the purchase of 2 new retinal cameras. Now, these are fascinating machines that can be run. They're simple as run that our medical assistants have been trained up and do all the studies. They're non-dilated exams, so the patients aren't leaving with the bulky glasses. And our endocrinologists are training currently to do the retinal screenings. Now, this is, once again, a screening study. So abnormal studies, of course, need to go on for ophthalmologist review, but the bulk majority, as in most screening studies, are reviewed. We get a time point. Those images can be saved, and then the patients can be rescreened annually as they receive their care for diabetes. And we have 2 separate cameras that we can position throughout the county. Then the data is stored and forwarded back to our endocrinologists to read. We're now currently, just based on that need, we've now found other applications for this as well, including screening during the treatment for hepatitis C with interferon, which can induce cotton wool spots or other retinal changes as 1 to 8%, depending on what data you look at. It can also cause a retinal vasculitis, and so getting a pre-treatment baseline is important. And then near and dear to my heart is plaquenil eye screening for my patients with lupus and rheumatoid arthritis. Another initiative that we've undertaken is formalizing our referral process and using a web-based system that can be utilized by not only members of the Ventura County Healthcare Center, but also all the community members, which to provide speedy referrals and access to our county specialists, but at the same time maximize the data that's received by the specialists. When you look at cost of care in depending on the specialty, a lot of the cost of care for patients that are uninsured is that first-time visit, getting in through the door. And the historical pattern of evaluation is bring in the patient, see what you need, and then send them off for lab tests and then have them come back, which means a second test. But if a lot of the testing and evaluation can be done prior, it can sometimes obviate the need for that second visit. I'm trying to go to the next slide. ago. So what we've developed are specialty guidelines. And now these are homegrown, we put in parentheses approach, where we've sat down with our specialists asking them given the given disease process that you're going to be working on, what exactly is the level of workup that you want to see that will help you along the process of first diagnosis and then secondarily appropriate treatment. Now, we've opted to not necessarily use national guidelines where there are some, but have rolled those into provider preference, but also through the coalition, sitting down with primary care physicians and discussing with them what is their comfort level, what data is it easy for them to get, and what not. And we started off with ENT because it was our most impacted specialty. We had 700 on our wait list, and he really took this and ran with it. In terms of embedded within the guidelines, there are teaching tools, reminders, gentle reminders about these are the treatments or these are the studies that can be used prior to referrals to an ENT. Now, with the e-referral system, these will all be codified into the web-based, easily printable PDF format, so that a provider, when he wants to make a referral, can then have the guidelines printed out, and it can be a reminder that, oh, wait a second, I haven't tried X, Y, or Z, and I might do that and save my patient some money, save them some anxiety, some time. Move on to the next slide, please. And so here's an example of our ENT guidelines. So for allergic rhinitis, failed 2 months of adequate trial of intranasal steroids. Consider having the patient seen by allergy first. Deviated nasal septum, he used guidelines based on Medi-Cal requirements. Dysphagia, get the barium swallow first, so that way he has an evaluation of the anatomy first. Same thing with globus. Try 2 different trials of proton pump inhibitors because that's the most common cause. Reflux is the most common cause of globus, or that feeling like something is stuck in your throat. So you can see that these are. This similar format is printed up to the provider so that they can look at it as they're considering a referral. Next slide, please. We've been able to develop this for multiple of our specialists, including my own rheumatology clinic, our endocrinologist. We're in the process of developing them for our pediatric specialists under the same ENT format. Now, some of our other specialists, like physiatry or physical medicine rehabilitation, which is another hybrid specialty where they do a lot of musculoskeletal medicine. They do some wound care, a lot of intra-articular injections. He can use the the referral guidelines to really guide primary care physicians on how to utilize him. Because he's recently new to our system, and as you launch any new specialist, there is the need to make sure that they're seeing what's appropriate, and his capacity to help the patients in Ventura County is very impressive. But given that he's a new specialist, there's some confusion about what is and what isn't the right kind of patient to send to him, and the last thing we want to do is bog him down or waste patients' time with patients that he can't necessarily help. As Diana mentioned earlier, we're also now developing psychiatry guidelines, which are going through the process of approval with our coalition. Next slide. So as I mentioned earlier, we have all of our guidelines are listed here, including neurology, otolaryngology, hepatitis C, physiatry, cardiology, psychiatry. Next slide. And we also have a guideline for routine colon screening and workup of heme and stool, including EGDs. But we're developing a more comprehensive guidelines for gastroenterology, pulmonology, and nephrology, kidney, lung, and gut. I think I'll turn this over to Diana now, because she's really been the spearhead for the development of the e-referral system.
Working on the e-referral system a little over a year ago. Decided to go with a private vendor and do a homegrown application. Based on my experience in this arena, I had developed 3 other software applications We found that going with your own vendor really does make the process a lot easier rather than purchasing something off the shelf and trying to majorly tweak it later on, which can be a lot of headache and a lot of expense. We have input from specialists, primary care physicians. Our developer is married to one of our primary care physicians, so she's always peeking in and seeing how she likes it and giving us feedback of ease to use. We've embedded the specialty guidelines in the e-referral system. We didn't make it that I know some e-referral systems have it that you can't even continue unless one says that they've actually done each specific test, say, for that specialty guideline. We didn't make ours that specific, and I'll show you how ours looks in a minute. Currently, we're beta testing internally, trying to work out all the bugs, and within 2 weeks, we should bring that out to one of our smaller ambulatory care clinics. We wanted to start a little bit small and then roll it out slowly. So in 2 weeks, one of our Conejo Valley clinic will be beta testing it with us and actually sending in referrals to us. So far, we've received a very positive reception. We've brought it to our clinic managers meeting, our medical directors meeting. Our head person on this is Ralph Reyes, and he's already been out into the community. Because remember, we do receive over 30% of our referrals into specialty care for the healthcare agency are from our community clinics and outside of the healthcare agency. So implementation, as I said, is within a couple of weeks, and we've already started out into the community. Here's this is just a test site, as you can tell, because we really don't have Bobby Flay as one of our patients, although we want to. So as you can see, it's a very simple application. We wanted it easy to use. Not only can providers use it, but referral staff in the clinic offices. When they log in, they immediately see their dashboard, and they can see all the referrals that they've put in. They can see the status. We have all these in new right now, but status would include that the RNs are under clinical review by an RN, or the appointment's made. They can tell the exact date of the appointment. And then we want to close that circle of, did the patient make the appointment? We're going to have on there, yes, no, yes, that's great. If no, we've developed a list of why I think every patient can't make an appointment. And so far we've come up with about 14 reasons that we can possibly think of. Because we want to find out, why aren't they making their appointment? Is it that the specialty clinic is just too far away from their home? If they live in our major city, Oxnard, and have to travel to Ventura and have 2 children, that may be 2 to 3 bus rides away and may take a couple of hours, and that is a huge barrier for them. So as you can see, we've made it simple to use, easy, and we're really excited about it.
I'm just going to interrupt here briefly. One of the biggest anxieties for providers when you're waiting for specialty care help is really, where are you in the process? And you have multiple patients, and you're not quite sure, has the patient actually been scheduled an appointment? Why haven't they been seen by XYZ? It's a complicated issue. And in this system, you can have multiple referrals. You can look at the patient, look at when the date was, or also signal back that, wait a second, the patient you're not getting any help because the patient hasn't been going to their appointments. And as a primary care, you can intervene as well. Then, if you're sitting there and getting frustrated and waiting for review, you can see that it's under review by RN, and that maybe if the patient's getting sicker, it's time to either email or call one of our providers to see if there can be a way to move up the appointment or to expedite the process. So just information is so key, and this is one of the first systems that I've had the pleasure to work with where really you get lifetime tracking of where your referral is.
The other thing I wanted to mention is that the specialty guidelines are everywhere in here. If you were to click on specialty guidelines, there's a drop-down menu. When you click on referrals and you're going to enter a new referral, and say you enter a neurology referral, they pop up in PDF form. There are reminders everywhere in the system about what the guidelines are. So it's not so much a hand comes out and slaps you in the face and says, oh, if you haven't done that X-ray, you're not going to be able to put in the referral. It's more gentle reminders all over. Plus, that with our support from Mr. Reyes, we'll be going out into the community of those people who are having difficulty with it or difficulty in, being compliant with the system and helping them out. So we believe in gentle reminders and then going out into the community and helping them.
Is this you or me, Diana?
Oh, you go ahead.
So where do we go from here? I mean, we have a wonderful new system. We have invested primary care physicians and specialists through the coalition, and so it feels that we're in a good place. But one of the questions that we, through the Kaiser Grant, need to constantly keep in mind is sustainability. And how do we maintain this system? And really, our plan is to show that this kind of system pays for itself. If you have patients that have more robust workup, you end up utilizing your specialists less time. They're more efficient, and with more efficient specialists, then you end up with not only better care but cheaper care. For that, we need a continued need for the coalition and champions on the coalition. There will be interesting challenges in the future. We, like many other big systems, are planning on developing an e-referral system, and so there will need to be future versions of the e-referral as well as updates, figuring out a way to integrate, which I understand we'll be able to do. And then we also need to start expanding out to encompass other specialists. And then also how we can expand the referral center to encompass things that traditionally aren't involved with specialists but are specialty care, such as procedures, EMGs, musculoskeletal ultrasound, epidural injections, under the guidelines of the specialist that would do that. So sometimes patients don't need to be seen by the specialist, they just need the specialist to do a particular procedure, especially when you're dealing with strong primary care physicians. Next slide. So we'll leave you with this last picture of a swimming hole up in Thousand Oaks. And are there any questions for Diana or myself?
This is Joni. When you say homegrown, does that mean that the specialist that's part of the coalition and the primary care physician shared information and you guys came up with the referral guideline? Or what?
Yes.
Okay.
So what happened is that Diana, and that's actually how I got involved. Diana came to me and said, have I got a deal for you? And as a specialist, we found great receptiveness from our specialists because the more data you have and the better educated primary care physicians are in terms of diseases that you consider appropriate for your care, the higher the quality of the referrals and the more efficient you are. One of the things that I think you can experience working with specialists is that one of the things that really specialists hate is wasting their time, or quote unquote wasting their time. And I know that sounds a little bit inflammatory, and it's not intentionally so, but there are a lot of times referrals that are made that don't necessarily need specialty care, and those can really bog down the system. And so our specialists have been very receptive to the idea of setting up educational guidelines, and then because we don't want this to be a pampered system where the specialists can throw up barriers to care, these are all vetted through the coalition, through primary care physicians, through other specialists to look and make sure that what they're asking for does make medical sense, to challenge in terms of, well, is there evidence based to what you're requesting for? Does this actually make sense? So the vetting process is very long, but it ends up really, it's really improved the quality of my practice, I'll say personally.
Good. The other thing I wanted to mention is that you really need physician champions in this to get it accomplished. Dr. Pearson's been one of our great physician champions who, with our hepatitis C guidelines, we really needed to have a sit-down with the gastroenterologist as to what is it that they wanted, because we had discussions at the coalition. So he went to their evening meeting to meet with them and go over the guidelines and say, do you have to have this? Is this necessary? Et cetera, et cetera. So if I have any recommendation is to get your physician champions out there for you to get going on really making your guidelines something that's palatable for both sides, and I think that's the most important thing.
Any other questions? We still have about a minute or two for a burning question. I know that you mentioned the champion and how important that is, Diana. And Anna, would you like to speak to that? Because I know that's something that you have used quite a bit in your process.
Yeah, this is Anna Alvarez. I think what Diana is talking about is having sort of one specialist that you can engage to lead the project, and that's the way that LAC-USC has done its work. We've found one specialist who's in each area who's willing to volunteer and sort of give their time, and that's how we've sort of gotten the project started in GI and in the other areas that we're working with, rheumatology and cardiology as well. So the flip side to that is that it does present a sustainability issue as far as what happens if that person leaves, and that's sort of one of the things that we're trying to address now. And I actually had a question for the presenters. I noticed that some of your guidelines refer to diagnostic tests, and I can't remember which area it was, but one of the steps was to refer that patient for a CT scan. And one of the difficulties that we've experienced here is including, once we include those diagnostics in the referral guidelines, the wait time for a CT scan may be 9 months or 10 months. And so has that required sort of you redoing the flow process for your diagnostics in the medical center?
Have that kind of wait times for CAT scans.
Our longest wait times that we face generally are, when we're dealing with underinsured, and I'll include Medi-Cal as underinsured, which I probably should, versus the uninsured. MRIs are our biggest barrier, but even then, if there is documented medical necessity. Now there are some double blinds that you do run into, and it's neurosurgery generally doesn't want to see patients that haven't had an MRI done. Now neurosurgery hasn't been incorporated in our coalition yet, but frequently Medi-Cal will refuse to do an MRI unless it's ordered by a neurologist or a neurosurgeon. And so as a primary care physician, there are those experiences. The way that we approach delay, so that if really if there is a patient that needs to be seen by a specialist and there is a particular study that is felt to be delaying appropriate care, there is always an opt-out, either through email or through phone calls. And phone calls can either be physician to physician or our outside physician contacting our referral center and asking for a review. And it's not infrequent that I'll end up with a review and then contact the physician myself, the specialist myself, and say, this is the clinical scenario. What do you think? And generally, it's that sounds okay. Let's just go ahead and get him in and get an exam. And we had a sick woman with an atypical, quote-unquote, Bell's palsy were pregnant, and this came up, and our specialist evaluated her and felt that an MRI was needed that day, and our hospital ended up, eating the cost, but it ended up being a tumor. So, we feel strongly that these guidelines and the diagnostic requirements put forward for the vast population are the right way to go.
Right.
But that there are opt-outs if the physicians think that there is an undue delay of care being posed or barriers to care being posed.
And also the registered nurses, when they do their review, if something really comes to their attention, they'll either call for more information, they'll call Dr. Pearson and say, just as he said, we don't have this test or that test, but I'm looking at this referral and I'm really concerned about it. Can you, take the lead on this? And he will. So we have this backup also of when we look at the referrals, what's going on with this patient. Many times it may be urgent, and yet there's no urgency on the referral form itself, and vice versa.
And that is an important point as well. Is that even though we have our new e-referral system, and the goal of that isn't to replace bodies, is to actually make the bodies more efficient, so our nurses can do more case management, have time to triage these cases, and they having it staffed at the level of RN, I think, has been invaluable. In terms of picking up patients that are maybe not getting the care that's needed in a timely fashion versus patients that might not necessarily need a specialist or being referred to the wrong specialist. I can't tell you the number of times that our RNs have flagged a case that probably needs to go to somebody else. And so it's the staffing of the referral center, the receiving side of the e-referrals has been exceedingly important.
I'm so sorry to end our conversation today. It is 1 o'clock. Again, I apologize for our delay. However, it is 1 o'clock, and to really respect everyone's time, we will have to end our session. Just one or two last comments here. First of all, thank you so much, Diana and Dr. Pearson, for your time and for your excellent presentation. And please, I ask and encourage all of you on our call today, see if you have any further questions that you didn't have a chance to ask, please feel free to contact Diana or Dr. Pearson or email them. And just briefly, our next session will continue our guidelines discussion on April the 6th, but next week we will focus on building and expanding specialty networks. So I think that in an effort to save time, I'll just send out an email to everyone to ask which approach you like. Do people generally like the presentation, or would you like to have a group discussion, or any thoughts on that?
Louisa, I'm sorry to interrupt you. Maggie just sent out the survey.
Great.
To everyone, so maybe they can respond on there.
Oh, great. Thank you, Debbie.
The format.
That's right. Yes, we are wanting to get your feedback, and so a brief survey of 6 questions is being sent out after each webinar for this month, just to get your feedback again and your ideas for any improvements or change. So that will be your process. So, any other comments or questions before we close?